full arch guided surgery is designed for safety, precision, quality results. It's not a race. I always say, I know a doctor who did one of these cases in 60 minutes and everybody in the room says, well, it's not a race, but I don't know, 60 minutes from incision to suture can be wonderful for many reasons. So our goal with this podcast is to hopefully espouse some techniques that can help get doctors under 2 hours of surgery. And I go to a lot of surgeries and doctors want to be quicker. They want to do these things quicker for the most part. My guest on this whole series is Dr. James Hamill. James, he's completed 55 arches on his own, and he has taught more than 100 in one-on-one coaching surgeries around Ireland and UK. And he consistently completes these cases under two hours. I've been there, I've seen it. It's impressive. And so this second section, James and I are going to talk about the pin guide and the fixation base. Maybe we'll drift a little bit over to the carrier guide too, but the main thing is the pin guide and the fixation base. And the key component is getting these seated properly. But I noticed that one thing you did when you were seating the pin guide, and you used the word always, and that related to how deep you drill and how you always tap in a pin. Yeah. And I don't always hear always. I hear sometimes, and I feel the bone first, or I know it's a lower, so I don't need to, that kind of thing. But I like the policy of always with the pins. They are designed with a step down function on the drill that's coordinated with the pin for always.
You taught me that, Alan. Okay. Oh. Yeah, right at the very start, when I started doing these surgeries, you stressed to me the importance of this step. And I've brought that on in anybody I've taught, because if you get this bit wrong, you're going to carry your error all the way through. So I call it the deep breath moment. And I say to the surgeon, listen, this is the bit we're not going to rush. And this is the bit that we're going to take our time, and we must get it right. So I suppose in doing the surgeries initially myself, before I ever went to teach anybody how to do it, I consistently followed that protocol of drill 1 mil short and tap the pin home. And it has never failed me. I've never had a loose fixation base. I've never had a problem with a fixation base. So therefore, why change something that's not broken? It just works.
Right.
And the difficulty, saying, I can assess the bone. When you're drilling through a fixation base, it's almost impossible to assess what that bone is like. Because you got this metal channel you have to put your drill through. So your tactile feel there is minimal, really minimal. So why risk it? I suppose I just don't see the reason to risk it. In the mandible, sometimes I think you can get away with it, but I will maybe drill to even if it's just 0.5 mil short, but I always want to tap that pin.
When you place the pin guide, you drill one, seat one, yeah. but you wait to tap, right? Drill one, seat one, drill the next one, seat one. Because I've been to different variations, many variations I've seen out there. I even was at a recent one where the doctor wanted to drill all of them and then start putting pins. And I can tell you that will cause error, because if that fixation base can move or drift at all, or it's not held secure, then the holes can vary just a little bit and you'll have a tough time getting them in. So drill, seat, all usually does 4, then go back and you still hold firm on the pin guide. Yeah, hold it firm.
So the way that I work with the pin guide is, and the way that I've trained the nurse that I work with in most situations, is that she holds the pin guide. Okay. And the reason that I do that is it gives me 2 hands free. I trust her implicitly. I can check that the windows, if it's a part dentate case, that the windows and the teeth or everything is lined up. But obviously I'll have checked that before. But I will say to the nurse, and I'll say when I go to the surgeries, once we start, you cannot let go. If your fingers go white and your knuckles go white because you're holding so tight, brilliant. All right. Because you got to hold this. This is your job. And it comes back to that communication and permission. So I will say to all the nurses, this is your role in this bit. Therefore, step up to the mark. It's a really important part, and actually they like doing it. But I've seen a lot of, I'm sure you've seen a lot of people struggling to manage the pin guide, manage the drilling, lifting up the soft tissue to make sure you don't pin the soft tissue. It's almost too much to do.
Gotcha.
So utilize your team.
So the pin guide sets the stage, as everybody knows. And interestingly, that's the one thing where you might slow down on, because if that's off, then the whole surgery is off. Pin guide seating can be very quick. I mean, yours was still quick and efficient because you had a system and the two people working on the patient knew the process. Repeat. Don't question it or guess on it based on bone density or bone depth or any of that.
Yeah, so there's a couple of things in terms of efficiencies with it, Alan. So is that when the nurse goes to hold the pin guide in place, all my pins are sitting right beside me. They're sitting pretty much, generally I put them on the patient's chest. And so therefore it's just a drill, lift, pin in, drill, lift, pin in, rather than drilling and then going to look for your pin, which often happens. Where did I put the pin? Well, Gemma, get me the pin, and the pin could be on the other side of the surgery. And in doing that, things can move because the nurse that's potentially holding it gets distracted. She looks up to help to look for the pin, where the pin is, and things move a wee bit. So you need to be organized. So I would say that. The other thing then is that I take the mirror head off the mirror handle and use that to place on top of the pin and then tap the top of the handle with the mallet.
Right.
And
I would totally agree with where the components are, because very often they're sitting in a Dixie cup over on a shelf being soaked, and they should be right as close as possible to what you're working on. Agree. Yeah. Organization of parts, even down to the pin guide. And of course, before the pin guide is laying the flap. And I noticed, during the surgery, you used the word always again, and that is you always elevate it beyond where you think the fixation is going to be, because that's if you leave it where the fixation base is going to be, you're still going to have to elevate it more. So do it the first time, but you also used two instruments instead of one, which I don't see that very often. You used a Minnesota and a elevator.
A normal sharp elevator, which is really important. If you're going to lift the tissue, you're going to lift the tissue. Let's just get it done in one swoop, because you see people doing a bit and then they try the pin guide in and then they do another bit, and then you lose 20 minutes messing about. Get the tissue up, but get it up nice and cleanly. So I was taught by brilliant consultants in Cheltenham Hospital about how to lift flaps pretty quickly. And the word that they always used to use was tension. Let's get a little bit of tension on the periosteum and this thing will fly up. So I used the Minnesota. So I started in the corner. So say I was going right to left, I'll start on the ridge. And the way I think about it is, if you've ever peeled wallpaper off a wall, okay, the way when you were a child, you went to the corner that just started.
Yeah.
You get it lifted up first. You don't run halfway across the wall and try to lift up another bit, because that's what so many people do. You've seen it. They try to lift it in 3 or 4 different places. Start at the corner and get that elevated down onto bone. Then put your Minnesota in, get tension on it. And then all you're doing is pushing against your Minnesota with a very sharp, really sharp, nice, clean elevator. Too many blunt instruments on too many tables. And you just see these people chopping and pushing and cutting, and you want one incision once with your blade, and then lift from the corner and all the way across.
And your pressure on the on the sharp instrument is against the bone.
So that the Minnesota is reflecting the soft tissue and keeping it under tension. Right. And then the sharp instrument is basically on the bone, pushing against the Minnesota,
shoveling it,
basically lifting the tissue.
Yeah. I really like that 2 instrument technique, and I don't see it very often. I thought it was really efficient. It also keeps the tissue out of the way while you're working. You know what you've already elevated, and just keep working around. It was very quick. All right, pin guide, and then also the fixation base. So pinning went well, pin guide comes off. favorite instruments for, for extracting teeth, that's easy enough. But favorite instruments for bone reduction, you used a very aggressive burr. And I see, a lot of our customers I've been to surgeries recently where they use a little BB burr for the finish and a big round burr for the gross reduction. But, the goal is flat. So why not get a burr that mirrors the flat? Was that a Mr. Hungry or a Meisinger? I don't know, what burr was that? You had a Meisinger barrel burr. Yeah. So, and I think most people know this because they've watched a lot of videos and seen it, but I noticed a trick that you had the nurse doing. And that was using a fairly wide spatula, and it was just to the lingual of the burr. And whenever you would grind bone into that spatula, and it would not go into the mouth, it would go to the spatula and it would run right off into a suction.
Yeah, there's a couple of reasons. One is to try to reduce soft tissue trauma. So that's why it's there as well.
Protection.
And secondly is it does reduce that spray of white everywhere. It's a bit of an art, I think.
Yeah.
Sharp burrs. So on a decent handpiece, that's important. A lot of people use fairly rubbishy burrs. You need a good sharp burr. And absolutely, I've gone away from the torpedo shaped ones probably to a more flat sided one. And that has helped. And I know that we have discussed that. When I say there's teeth to take out, I will reduce bone around the teeth. So I'll generally fissure burr between each of the teeth, which helps the extraction. And I often fissure burr across the buccal so that if there's going to be a buccal fracture of the bone, it's more controlled when you're taking the tooth out. So if you do that, I think that helps speed it up a little bit. I haven't used it personally, but one of our customers used piezo recently, and it was wonderful.
For that function, for releasing the tension around the bone.
No, he did everything. He removed his teeth, and he done his full bone reduction using piezo.
Did you find that it was a smooth surface?
It was incredibly good.
Oh.
Yeah, incredibly good. And then he finished it with a ceramic burr.
Okay.
At the end. He's very used to using piezo. I don't think I could do it as well as he did it without some practice.
I don't see many anymore.
That's the first time
I did
I've seen it.
a couple of years ago. I saw a few years ago, but I mostly see burrs, rongiers. Sometimes I see a little burr scoring, and then rongiers to take the bulk off, usually oral surgeons.
My concern with rongiers is lack of control. You have to have it well cut first. So you need to have your fissure burr cuts, because I've seen people do rongiers without doing that particularly well, and bone breaking, shelving up into the palate. And obviously your implants are going to be more palatally placed. Therefore, you're dealing with a lack of bone then. So I think rongiers, you need to know what you're doing.
Yeah, and Jimmy had a lot of bone reduction. It was 7 millimeters and 6 millimeters in some areas. Maybe if I get the measurement right.
But there was one particular area was probably about 6. The rest of it was about 3, 4. But
sockets.
But his bone was rock solid. Don't forget.
Yeah, it was really fine Irish bone. In some situations, I would see doctors probably grabbing a rongier for that bulk of bone. But because you had that spatula, you knew you could control the volume of bone flakes going into the mouth. Because I see it, sometimes it looks like a snowstorm in there after a really aggressive. The burr worked great, but then you have other problems: suction getting clogged and bone going in the throat. And
we generally don't have that issue, I have to say, using that technique, because any bone chips are really well irrigated. There's so much water there as they hit the spatula or hit the retractor. So we don't generally have a problem, I have to say.
Adjusting to loosen teeth come out mostly aggressive burr. And then I think that was my notes on that. But the other is confirming. And
yes,
I've been to surgeries where the carrier guide might have been used 4, 5, 6 times to either figure out if it's tissue or bone, and it's 10, 15 minutes or more trying to get that bone level. And I think the combination of the nurse and the doctor looking down the plane, feeling it with your fingers, visualizing it, and then using that flat barrel burr, between those 3, you really should be able to do just about everything before you even try the carrier guide. You should be able to see it. Yes?
I see that probably as one of the most critical points where doctors get frustrated, is managing that checkpoint, which is your carrier guide going to fit after you've adjusted the bone? And if you think about it, if you have good palatal reflection, that's going to help that first situation. So you
because
really
the hang up is usually on the lingual posterior.
So really you've taken that problem away by doing it right in the first place. And the second one then is problem solving. It's about problem solving. All right. So if that carrier guide doesn't fit in, deep breath time number 2, let's have a look. Okay. Rather than getting frustrated and annoyed because you want to get to the next step, which I get it, because all these doctors want to put implants in.
Yeah.
You take a deep breath and you use your nurse, because sometimes your nurse can see things that you can't see.
Right.
And have a little look where the blanch is. Get your nurse to use her suction, get a probe, feel it into the holes.
With the carrier guide seated.
Yeah. So what I often do, and you've seen me do it, Alan, is I'll put the carrier guide on and I'll generally pin the anterior pin first. So that, because usually it's pretty easy to get in. So I'll pin the anterior.
Okay.
Then that gives us hands free, and you can then push on it and see, right, well, where's it flexing? Where's the blanching? But it is about problem solving. So you have to put your problem solving hat on at that point.
I like the perio probe part, because you can go in the hole. Yeah. Because you can usually visualize it, but you can spin it around and see where the space is, see where the rock is. You'll feel the fulcrum. It's kind of like trying in a partial framework. But I agree. A second set of eyes on the other side of the patient with the assistant of the nurse is key. And that's where you get, just like you said in the first podcast, get them involved, allow them to speak and allow them communicate to help. and help. Yeah. And a lot of that is bone reduction, because most of it is visual.
Yes.
You can visual. I mean, the fixation base is going this way. The bone is going this way. Visualize where it's got to be flat from a couple different angles, and you'll succeed.
It's the old classic, isn't it? People leave it high on the palatal or high in the lingual. Like that's
almost every time. Sometimes, in the anterior, there's, concern about nerve bundles, that kind of thing. Sometimes that there's a little bit there, but
probably my last point on this one is I do my surgery standing up. Some people do it sitting down. Move around the patient. So get yourself up, move around, look at it from different angles, and you'll see different things. If you just sit in the one place, you're only going to see the thing in one direction or one dimension. So get up and move around.
You performed your surgery standing up. Is that an always? Always standing up. Yeah, because then you're thinking, I want to get this done in 2 hours, because I'm going to be darn tired if I got to stand up for.
Yeah.
Or your back, your neck, your back. I mean, just stand up and lift the patient high, right?
Yeah. I suppose that's the way I've always done it. So
one last thing on this, since the carrier guide is on,
it's
passive, it's clipped in. That's the time. It's choice, but that's the time to put in either the rapid appliance or the prosthetic and check bite before the muscles are sore, while the patient can hopefully still be pushed in, and then you can see where you are. How close is the bite? Is it right on? Do I need to do anything?
Totally. I that's another always. So I check it at that point, because it gives me a wee heads up. So am I close, or am I going to have to do work later on?
Yeah.
And it just prepares me, and it also prepares the team. So I might put that in and we go, you know what, I think we're going to have a bit of work to do on the bite. So everybody knows it's not a surprise. The patient also knows, and I'll say, the bite is okay, but it's not fantastic. We're going to have to do some work at the end. Therefore, it's maybe going to take us an extra 10 minutes to adjust this. But you're right. If you only do that at the very end, muscles are tired, everybody's laying back.
Right.
It's just a nicer time to do it. I think it's a more accurate time to check it.
Well, and it's not something you folks are doing so much in Ireland, but over here we do a lot of the C2F, and we want to capture bite for some of these cases. Actually, we end up not using them because CHROME, it's not an advertisement or anything, but CHROME bites are very accurate. It's really rare that something is off, but if it is a little bit off, and you're going to articulate, and do something extra orally, like an extra conversion. Take the bite before the muscles are sore. I hope that I hope our audience is picking up some tips with efficiencies. I hope so.
Hope so,
that
yeah.
that'll conclude section number 2, and tune in for section number 3. All right, I'll see you then.
Yeah. Thanks, Alan. Bye-bye.
Okay.